Hi, good morning, everyone. I'm just waiting as the webinar is opened up as people are filing in. I can see the number of participants skyrocketing in excitement to hear our today's Grand Round speaker. I'm just going to wait till it gets a little higher and then we will get started. But I want to welcome all of you to Grand Rounds for this morning.
And who's next week?
Yes, so why don't I start with announcements? So welcome everyone to Grand Rounds. I'm Jeff Miller, one of the co-directors of the Grand Rounds series in the department. We're so pleased to have you here virtually. So we have some announcements. Next week's Grand Rounds presentation on Wednesday, October 13th will be given by Dr. Claudia Garcia Moreno. It's in honor of Domestic Violence Awareness Month. And the topic is Intimate Partner Violence Against Women, a Global Overview. Dr. Garcia Moreno comes to us from the World Health Organization, where she's the unit head addressing the needs of vulnerable populations unit in the Department of Sexual and Reproductive Health and Research. So that should be a fascinating talk. I have two quick announcements before I turn it over to Dr. Lieberman to introduce today's Grand Round speaker. The first one is a request to all of you to make suggestions to us about who you would like to hear from in upcoming Grand Rounds. So I'm going to post a link in the chat for all of you to fill out a survey to nominate Grand Round speakers. We really are hoping to have a diversity of voices across as broad a diversity of topics as possible, relevant to psychiatry, very broadly construed. So please click the link. Don't fill it out during the speaker's talk, but bookmark it. And at your convenience, please send us some suggestions. And then my last announcement before I hand it over to Dr. Lieberman is just about the Q&A. So we welcome questions of today's speaker. I will moderate the Q&A at 12 o'clock after our speaker's talk. Please post questions not in the chat, but in the Q&A function. If you hover to the bottom of the screen, you'll see there are two separate things, the chat and the Q&A function. We just want them to all go into the same place. And we will prioritize questions from trainees during the Q&A section. And I would welcome you to identify yourself as a trainee, if you are one, by putting the word trainee : at the beginning of your question. Thanks so much. We're thrilled to have you all here. And Dr. Lieberman, I'll hand it over to you to introduce today's speaker.
Thanks, Jeff. Good morning, everybody. It's a real pleasure to have a speaker today who is not someone who originated in the East Coast in New York at Columbia in our training, but by dint of fate and interest has become one of us, a New Yorker and a faculty member, Dr. Moutier. Dr. Moutier hails from the West Coast, Seattle, Washington, Southern California, and went east for her undergraduate school at Vassar, but then returned to California for her medical school, postgraduate training, and a faculty career at the University of California, San Diego. And in looking at her CV, it was early on readily apparent that she had gone into medicine and into psychiatry as an individual with a great deal of personal interest in humanity and compassion, because her work right from the start was involved with studying issues about depression, suicide, trainee or student well-being, and had a very good mentor for a lot of that in the form of Sid Zissek, who's a very well-known figure in the field in this area of not just mood disorders, but those that may afflict healthcare providers. At UCSD, she sort of rose through the ranks in terms of the psychiatry department, but then also was recognized for her broader range of abilities and became assistant dean for medical education and then for student affairs, before an opportunity in 2013 arose to become the chief medical officer of the American Foundation for Suicide Prevention. So she decamped to New York, has been in that position ever since, and has made a huge difference in terms of the impact and the scope of influence and awareness of this phenomenon that has been ever present among humankind. But even though we have a great deal of knowledge and capacity to impacted beneficially hasn't been taken as seriously as it should be in terms of policy and in terms of preventive measures through various types of healthcare services. But Christine will remedy that in due course. We took advantage of the fact that she was in the neighborhood and working in an area that was of public health importance, and also an area of research interest of a number of our faculty, to invite her to have a faculty appointment. And I'm pleased to say that she's been appointed in our department. So anybody out there listening who wants to interact with a real expert in this area, she's open for business in that regard. She's done the usual academic things in terms of publishing, but in her role as an AFSP, she's also become a public voice. And as you'll hear in a moment, you couldn't have a better spokesperson in terms of her knowledge, her communication ability, and just a persona to be the face of a major public health problem that we're in a position to improve, and to be able to sort of lead this in a way that's important. And the other thing, I guess, what I'll mention is that apart from being an organization that's able to foster awareness, the AFSP also has been a very important source of research funding over the years. And a number of our faculty have benefited from the largesse and the wisdom of the organization of funding scientifically meritorious projects. So it's great to have her with us today. And like I say, you'll be seeing more of her in the future. So please join me in welcoming virtually Dr. Christine Moutier.
Thank you so much, Dr. Lieberman. What a wonderful welcome. It is definitely a pleasure to be here with the department, and to meet you all, and hopefully soon in person, and to get to know you and your work and your interests more as well. So I will be speaking to you this morning about physician and more largely health professionals, mental health and suicide prevention, and try to give you a smattering of various different angles on where we are now with the issue of physician and health professional suicide, but the actionable strategies that we can all take. That's what I will end with. My disclosures, as Dr. Lieberman said, I do work full-time at the American Foundation for Suicide Prevention. I'll introduce the organization in just a moment. One of the things that we do at AFSP is that we've developed and we actively license a program called the Interactive Screening Program that I'll mention in my talk. And I've recently published a clinical handbook on suicide prevention through Cambridge University Press. So if anyone's interested in something that hopefully you can kind of use during a busy clinic day, please check that out. So at AFSP, this is our mission: to save lives and bring hope to those affected by suicide. And that is obviously a big, audacious mission. But the beauty of how we do our work as an organization is that we do take a comprehensive public health strategic approach. And we're a sort of medium-sized nonprofit organization in the world of nonprofits and voluntary health organizations. But we are very proud of the fact that we're the leading private funder of suicide research globally. We have a very strong voice at the federal and state advocacy level, and that's because of our chapter network across all 50 states. We have tens of thousands of individuals who are all personally touched by suicide. Many are also, all walks of life, but some are also professionals and clinicians and researchers like you all. And you can become a field advocate as well. And some of you are involved with our local chapter. So thank you for that. We also develop education programs that have, over our last 10 to 15 years, had largely focused on lay education of teachers, educators, faith communities, policymakers, now workplace leaders, but increasingly now there's a readiness for clinical education, obviously, on suicide prevention as well. So that's become an active area for us as well. we were founded by a group of families who had lost loved ones to suicide, who met researchers and decided that there needed to be more research related to suicide risk and prevention. And it's important to note that part of our DNA truly has continued to be not only an emphasis on the research and doing things that have the evidence, but also part of our DNA is that commitment to suicide loss survivors. And ongoing, many people become newly bereaved by suicide of a loved one, and there is a whole arena within suicide prevention that's actually focused on the support and healing of the experience of suicide bereavement, which is a particular important area, because as we say in suicide prevention, postvention is a form of prevention for a variety of reasons. So this morning, I'll structure my time with you before we go into a Q&A, and I hope you will not be shy and put anything that's on your mind in the chat, please. First, taking a look at just sort of a broad national landscape of where we are from a very kind of global perspective related to culture, as well as some data. We'll then take a very quick dip into suicide and what really constitutes effective evidence-based suicide prevention. I'm not going to do it justice because that's going to be about 7 to 8 minutes of my talk, but I'll do my best. And then we're going to turn our focus to physicians and health professionals and look at what we know about distress, stigma, and suicide, and then lastly, what can be done about it. And I'll just start by saying that I have a very specific reason that took me on a journey that has taken me to devote my entire life's work to understanding and really implementing suicide prevention. And I'm a psychiatrist, but interestingly, it was more driven by a very personal experience of suicide loss of a medical student I worked with when I was a resident at UCSD. And then following on from there over time, in the course of my career, joining the faculty and becoming a dean in the medical school, there were a number of faculty physician suicide deaths, more than a dozen over a period of 15 years, which for an institution the size of UCSD, which at the time was about 2,500 faculty and residents and medical students, was a lot and notable. And like happens in so many places, when suicides are occurring, they are not always recognized as such. They might even be kept relatively insular. I had heard stories at UCSD with one clinical department in particular, after they had lost a physician to suicide and had their faculty meeting a couple weeks later, that it was not mentioned and was never mentioned. And so we all know we live in the world and stigma is reducing, but it is still the case, or if it is changing in your world, and I hope it is, it wasn't that long ago when there was a shroud of silence around these experiences of suffering, suicide attempts, and suicide loss. And so what we did was essentially Sid Zissek and I were sort of charged by the dean of the medical school at the time to get to the bottom of this. And what he meant by that was, how many people have died, and is there a science to inform that there is a relationship between an individual's suicide risk and the environment, the work or the learning environment around them? And, at the time, and even to this day, that's not a simple question. And so we took a couple of years and eventually launched a program at UCSD called the HEAR program, which stands for Healer, Education, Assessment, and Referral. And it is still ongoing today, about 13 years now into the program. And I'll just briefly mention what we decided to do in the beginning. we combined a massive educational campaign. And by that, I mean, we knocked on every door in the health system at UCSD and did something like 26 grand rounds and presentations in the first year of the program. And we combined it with AFSP's interactive screening program. At that time, I did not know AFSP very well. We found that program as a unique offering, and I think it continues to be an important part of UCSD's and many other health systems. And honestly, now it's in law enforcement units and corporate workplaces around the US. So the UCSD experience, we've published on it a number of different times. And essentially, I think what we know from any suicide prevention program is that it needs to be customized, but very strategic and evidence-based. And then the key thing is sustained over time, because what you see is a growth and a progress of sophistication that can evolve over time, that can truly lead to what we think of as more broad culture change, where it becomes a safer environment, not entirely, of course, because we have our own sense of internalized stigma and shame at times, but there have been a number of positive indicators, including literally hundreds of faculty, physicians, and trainees who have engaged and been referred into treatment. Many other engagements that come short of that treatment help seeking as well. But I only tell you that because it was a very personal experience to try to get something going like that program. It feels uncertain and messy while you're doing it, and only after you start measuring your outcomes and take a step back over time that you can see the results. And in those years, those early years, between about 2004 and I'd say 2012, 2014, there was a lot of, I'll just call it, cultural resistance and denial going on. And I'm talking about in the national level of academic medicine. And what happened in about 2014 or 2015 was a complete 180, where we saw organizations like the ACGME and then ultimately the National Academy of Science recognize that trainee and physician, and more broadly, health professional distress is a serious issue, and one that affects not only an individual and their family's quality of life and health, but has an impact on the sort of entire industry of healthcare in terms of morale, well-being, patient care, turnover, and many kind of measurable indications or outcomes that are now known to be linked to the issues of mental health and well-being. And so I think now it is a time when every national and local, professional organization and healthcare organization has become interested, if not invested, in doing something. And I think the question now is, rather than that sort of resistance, it's now what should be done and what has the most evidence or promise to say that you'll have an impact on your community if you do X, Y, and Z. And again, at the end of my talk, that's the part that I'm going to end with, looking at those actionable strategies. But just to take a step out and into the 30,000-foot view of our sort of national culture, if you will, around attitudes towards mental health and suicide prevention. Every couple years, we survey the American public through using Harris Poll. And during COVID, it had already been trending to the point that more than 90% of American adults who responded to this Harris poll would say that their mental health was valid, was as or more important than their physical health, but things trended even more so in that direction during COVID. And in fact, through the CDC Household Pulse Survey, if you've noticed that really interesting approach that CDC has taken to looking at mental health experiences and attitudes and help-seeking behaviors, help seeking and trying to connect to mental health treatment and services went up during COVID. And you can actually look at it according to demographics, which is really a fascinating thing to see. It's also unfortunately the case that there was a little bit more of a gap widening in terms of being able to access services. Now, so stigma is going down. Mental health is being recognized as a valid part of health. All of these, relatively well-known musicians, celebrities, influencers, athletes have been talking about their mental health or experience of being suicidal or losing a loved one to suicide. And so the point here is that disclosure can be an important tool in reducing stigma. It does need to be done in a way that is effective and safe. There are less productive things that can come of disclosing personal experiences when issues are very raw, or when a positive, hopeful arc where there are elements of trusted resources, treatment that helps, supportive colleagues and family. Those are very important parts to a story. And of course, we at AFSP, as many of you may as well, work with many content creators. Whoop. Looks like my sharing just paused. Can you all see my slides still?
Yes.
Oh, okay, good, okay. So, and what I wanted to say about this just quickly is that in addition to those, broader nationally known celebrities within the field of healthcare and certainly within medicine, if you notice in journals like the New England Journal, and certainly if you're on social media, you'll see self-disclosure happening a lot these days. And again, this is a very important thing that's happening. It does need to be done safely and well, and also the person who's sharing needs to be ready to do that. But I hope that if you hear colleagues sharing their own stories that may seem quite private, and that you will encourage them and thank them for doing that. It takes a risk, to step out and share something private and personal in that way. But I think the more that we can be authentic, but be encouraging of one another, the more we kind of get past that old sense of stigma. Okay, so let me just move quickly into the next portion, which is really just presenting some of my thoughts that are very kind of integrative worldviews, if you will, having been trained as a psychiatrist and then advising hundreds and hundreds of trainees in a more holistic manner, not serving as their psychiatrist, but as their advisor and as a dean, and doing that for colleagues over time. What I came and then also researching burnout and depression and suicide amongst physicians and trainees. What I would say is that mental health exists on a full continuum. Of course, in psychiatry, we train on syndromes and those illnesses codified in the DSM, which I'm 100% in on. But I also see this longer continuum, just like you could think about physical health and different sort of axes of health exist on a continuum. And what I would say is there's no need to feel sort of perfectionistic about this as we're on our own learning journey in terms of our own self-care. That during COVID in particular, but at all times, honestly, there are times when we're struggling to be in the middle there and to be coping. We don't always need to be in the performing and flourishing end of the spectrum, but there may be things that we can do to not only decrease the likelihood of crisis, but to augment where we are tending to live at baseline. And the right side of this slide is basically my poor attempt to kind of visually portray the way that I see this very integrative model, which is not going to be new to any of you, but I teach this a lot to lay people, that the outcome in terms of our mental health is very much a dynamic interplay between internal genetic, early psychosocial experiences, early family attachments, all of that plays into our mental health, and it's in a constant interaction with our environment. And so that is also true of suicide risk and protective factors, that when we look at the overall literature in terms of what we know about suicide risk in particular, what we see is that in the vast majority of the studies, really every study that knew, we're always looking at it from this angle, and especially from the psychological autopsy method, what you see is that in any instance of suicide death, as well as attempt, that there are numerous risk factors that are interacting and converging. I almost think about these latent, invisible risk factors being sort of like, if you picture the cloud of gaseous materials before the Big Bang occurred, that they're present and interacting, but then there is a moment where something coalesces and something can suddenly change, and that acute suicide risk, which now is being studied as a specific acute suicidal syndrome, can occur. And if people can live through that moment, there can be tremendous hope for healing and recovery. And so suicide prevention requires obviously a very multi-pronged approach, where we're learning not only as clinicians, but as a society to recognize what the basics that show up, that parents can learn to recognize in terms of risk factors, that teachers might play a role in helping engage at-risk students into mental health care. And of course, access to lethal means has a lot to do with suicide rates in particular, and suicide risk, and protective factors exist as well. And so again, this is more, we kind of try to depict this for our lay audiences to show that what you see from the outside and the way that the media had been portraying suicide oftentimes as a sort of simplistic one cause effect phenomenon, because that's what you can see in the person's life externally, the breakup, the financial crisis, et cetera, not understanding that there may be, and this is just, hypothetical here, there may be genetic risk, there may be an underlying depressive illness that was or was not ever detected or treated. That's, many times people who die by suicide, about more than half the time, were not in treatment at the time of their death. Some never having had their mental illness diagnosed or addressed. So it's to really round out this picture so that we understand and resist the temptation, which is such a part of our human nature, especially if you're not clinically trained, to look for one thing as a way to sort of understand, because your brain wants to make sense. If you've ever lost somebody, or if somebody in your life has attempted, you want to understand what was the main factor. But I would just encourage everyone, always be thinking, what were the factors? Because there are always multiple. And again, it has a direct kind of application in terms of what we think of for suicide prevention. And so just, again, this is not a comprehensive listing at all, but some of the top scientific findings that I think have an important pragmatic implication, both for clinicians as well as for non-clinicians, are these issues that I've tried to summarize here, that there are patterns of risk. The path to suicide risk is heterogeneous, but there are these patterns and again, converging risk factors. And the role of mental health conditions, psychiatric illness, I think out there in the wider world may still be not, it's still underestimated. So it is the case that in the vast majority of psychological autopsy studies, there had been a very likely psychiatric condition that, again, may or may not have been identified. Genetics do play a role in with regard to suicide risk. But the good news there is that there's important science going on to understand that better, which could have some direct application at a later point in time, we hope. But also that one's past history and genetic loading are not a person's destiny. We know that, obviously. Epigenetics goes both ways as well, right? Therapy and support can change the expression of genes and the outcome clinically. So the suicidal mindset is one that we do think is important to understand. for people to understand that there is a cognitive narrowing and constriction that occurs during that acute period that lasts minutes to at most really hours. And it's usually a very short period of time. That what that means is that for that moment, they may lose the flexibility to be able to creatively brainstorm other coping strategies, and they become very honed in on suicide as it's a coping mechanism. It's a solution to the sense of desperation, hopelessness, or pain that the person is in, their sense that it cannot change. But the truth is that after that moment passes, the brain then physiologically comes back to a more settled baseline place where they can think of other options. And so this sort of one way that we use this piece from the science is to dispel the myth that some people are bent on suicide, and that which is not the case. There's always ambivalence. And when you can help keep somebody safe in those acute moments, again, that can be actually effective suicide prevention. And so there are a number of important findings from the science, and this just doesn't even scratch the surface, but these are some of the just kind of top ones. Now, the finding that shame, humiliation, rejection, and despair are some of the common experiences for suicide risk. And of course, hopelessness being an overarching thing that ties some of that together. That, I think, is going to sync up with when we start talking about physicians and health professionals in a moment. Because when you think about the experiences that we as physicians and health professionals have, which I'll get to again in a moment, we may have our own sort of unique pathways to feeling shame and humiliation and rejection. And in fact, in the physician suicide literature, which is a small one in terms of psych autopsy findings, job issues and humiliation, fearing problems related to their professional practice is overrepresented compared to the general population in terms of job incidents prior to suicide. Okay, so I think I've talked enough on these. And the thing that's just the most basic thing that we can say then, after looking at all of that science together, is to say that while complex, suicide is a health issue. And that's a very grounding principle that I know this department is way ahead of the 8 ball, because your department is one of the most active and long-standing in terms of the dedication to suicide research. So thank you for cultivating that, because truly that now there are other places, but that was not always the case not that long ago. And but this is important as a grounding principle, because if we think of and understand that suicide is a complex health outcome, that has incredible practical implications in terms of applying a public health model, in terms of identifying and prioritizing suicide as a clinical issue that health systems can prioritize and start tracking and training to and developing policies and protocols around. Okay, what it also means is that the lexicon that we had long used around suicide doesn't really make sense anymore. And specifically, I'm talking about the phrase commit suicide. So I think this group probably is, again, more well aware than most that the preferred language is died by suicide, or just plain language like killed himself or took her life, ended their life. Those are all acceptable. It's that commit because it implies a morally reprehensible act, which if you understand the science, that doesn't fit. And we don't use the phrase committed cancer, for example. That would just not even make sense. And so we encourage a health-framed kind of language. And in the clinical arena, sometimes because, especially in training, there is a sort of selection bias towards addressing clinical issues and patients who tend to have more chronic and recurrent suicidality, where there may be, an overlay of many different comorbidities, including personality disorders. We want to try to get away from pejorative language that uses phrases like manipulative, when we mean that in anything that implies that it's not, that they don't carry serious suicide risk. We also recommend avoiding terms like successful or failed attempt. Again, that implies a value judgment that doesn't really make sense. Now, during COVID, we've been obviously very busy focusing on what data exists related to suicide and mental health distress factors during COVID for the population. But we also have been coming together as an international group of suicide experts and really publishing everything we know based on previous science that would say, okay, here are the ways that COVID could be pressing upon risk factors for a given population. And of course, it's going to be different risk factor buckets for each person and each population. But I did publish a paper in JAMA Psychiatry last year that took a look at these areas for really for prevention strategies to be employed. And, in some ways, they're the same prevention strategies that we've been kind of, ringing the alarm on with regard to our federal policy advocacy, as well as at the state level for a long time. But there does appear to be the political will ramped up during COVID. And so there are some silver linings that have happened. The fact that over the last year, we've seen 50 state bills pass that relate to mental health and or suicide prevention in 1 year. And that is more than probably the previous 3 years put together. And the same thing on the federal level. So there are some silver linings, the community cohesion that we've experienced, normalizing a dialogue around mental health distress and suffering actually can be a very good thing, especially when it leads to people being able to talk about what they're going through and get professional help when warranted. And of course, the telehealth services opening up and those policies. But as Dr. Lieberman said at the beginning, we have only just begun as a nation. We really have yet to see suicide prevention. We've had a national suicide prevention strategy since 2012. In 2020, it got sort of refreshed, but we have yet to fully invest and scale those actions that do constitute effective suicide prevention, which I'll come to later at the end when we're talking about strategies for physician suicide prevention, because many of them are actually overlapping with the CDC's recommendation for community-based suicide prevention. So I'm focusing next on physicians, not to be at the exclusion of any other health discipline, but more because the data around especially suicide, but many aspects of distress have been most studied in the physician cohort globally and including in the US. Now, the nursing literature for nursing experiences of distress and suicide is just now ramping up. And actually one of our colleagues at UCSD, Judy Davidson, is a nurse scientist who is really, I think, one of the leading people studying nurse suicides, as well as she's part of the UCSD HERE program group and has been involved in the program at large for a while. So there are some characteristics that draw many of us in the health professions to our work and to our field. And it's not to say that we all are clones of one another. We certainly are not. We're all unique individuals. But there are some things that allow us to really feel that calling or that pull to become a physician or in a different health discipline, same thing. And some of these also are very, very highly adaptive in terms of the academic and professional journey to become a physician. And then in patient care, you want your doctor to be somebody who is a little bit on the compulsive side, who thinks of every possibility and circles back and is paying attention to your clinical presentation. But when you think about who is in your life as a friend or a significant other, or even in a collegial relationship, these traits are not the most adaptive things. And life is very messy and unpredictable. As much as we like to have plans and a sense of control, we also need to learn how to practice that side of that uses a different, I think of this as almost like a volume control, and we need a different dial where we can dial up flexibility and a tolerance for ambiguity and uncertainty. And it's certainly during COVID that has been pressed upon. But any profession where there is a sort of hypertrophied value on self-sufficiency, that is a problem for suicide risk and suicide prevention when other vulnerabilities are present. And so this is not to say that physicians or any health discipline are sort of unique in the world in this way, but it is to set the stage because we, by the way, we also at AFSP work with many different law enforcement units and at the national and local levels and military, there are a number of occupations. The agricultural industry and construction industries have the very highest suicide rates. And if you think about the culture of stoicism and self-sufficiency amongst those groups, but still, we should be self-aware that if we're carrying some of that, we need to become more aware of that and learn how to flex towards practicing other aspects that are also in our human armamentarium, if you will. Now, again, this is not going to do it justice because there are many, many studies looking at everything from burnout to depressive symptoms, to anxiety symptoms, to PTSD screenings, to substance use and addiction, and suicidal ideation and suicide rates. But the short version here is that amongst the physician and medical student and trainee literature, almost every indicator of distress that is being studied is showing outcomes and a prevalence rate that tends to be higher than the non-medical age-matched cohort. Now, when it comes to suicide risk, there have been a number of different more recent meta-analyses, including a couple just in the last year or so, that seem to show that that physician suicide rates are too high, but that there may have been a trend downwards over the last several decades. And there almost certainly is a higher risk for female physicians than their non-physician female age-matched cohort. For male physicians, it's not as clear that it is overrepresented or that male physicians have a higher odds ratio of suicide compared with the non-physician male general population. However, there is still very much a sense that we can do better. We are educated, we have access to healthcare. We need to identify what those barriers are and find ways to address suicide rates. Now, there are known barriers to care, and the barriers for help seeking and for accessing mental health services are quite well studied and continue to be. But a couple of data points I'll point out. In the physician suicide decedent psych autopsy studies, and there are only a couple, so this is small scale, but again, the prevalence of mental health problems in those physicians who had died by suicide was about the same as the general population suicide decedent group, but the physicians were less likely to be accessing formal treatment. It's also true that physicians who take psychiatric medications oftentimes are taking them via self-prescribing or informal curbside consultation with a colleague. And that is something that I've come to see as a really practical and significant issue that needs to be addressed, because while it's tempting to treat your own sleep or anxiety, it does a couple of different things that could actually elevate the risk for that individual. There is a lot of concern about the medical licensing practice of asking questions about mental health diagnoses and treatment. And there are a number of reasons to believe that that is not only an ineffective way to detect problems with safe practice and competent physicians, but it also has been driving fear and stigma and driving mental health conditions and suffering and even suicidality to go underground, to be not formally addressed, and frankly it is an illegal and unethical practice that that many state medical boards are changing. But because the state medical boards were behaving that way, many hospital privileging committees also took the same tact. And so if you have anything to do with your hospital's privileging practices, make sure that the questions that are being asked about impairment and competence do not ask for diagnoses or treatment history for physical or mental health. It can all be lumped together as, are there any health issues that are leading to problems with competent, safe practice at this time? So there's a way to ask that question that is done correctly. So all of these barriers are significant and real. And when we're designing programs to prevent suicide, we need to find ways to overcome these external and perceived barriers on the part of the population that we care about. Now, it's also true that when you are distressed, your brain tricks you and you think differently than you do when you're not depressed or distressed. And so here's a study of medical students that shows that the non-depressed group, most of them said that if I were depressed, I would seek treatment, almost 90%, but less than half of the depressed cohort said that was true. So there's a sense that comes over us when we're the ones in distress, and we need to be acutely aware of that as colleagues and as leaders, that suffering in that place is very, very vulnerable. And there's an added layer, even if that person is the biggest advocate for, stigma reduction and all of this, like myself. But when I'm the one in distress, I may or may not hold on to those truths. And we need to understand that. Also, turns out physicians are pretty terrible self-assessors in terms of our own level of distress. So in this study by Shanafelt and his team, the physicians in this cohort that were at the bottom, 30% of the well-being index score, the majority of them thought that their well-being was at or above average. So we have a lot of trouble reliably calibrating our own level of distress. And I think as a profession, we tend to rationalize and normalize distress because it's a survival mechanism, of course, and it's a defense mechanism, but we do that to our own detriment, to the point that we say it's, I've heard when I first started my work with the HERE program, a trauma surgeon said to me, if I didn't experience every single one of those things, including suicidal thoughts was on my slide, pretty much every day, then I must not be doing my job well. So that kind of distorted rationalization of distress, it can be very commonplace and another barrier. And I'm going to have to just go through this very quickly so we can get to questions in time. But during COVID, there is reason to be additionally concerned. And it's just important to understand that COVID is not the only stressor and the only thing that's pressing on distress and risk. Obviously, these issues have been known to be problematic among physicians and trainees and healthcare workers in general for many years. And for those who have, we're all on our own dynamic journey, like I said at the beginning, in terms of that full continuum and that constant dynamic interplay between internal and external. And so COVID could be and what COVID means for each of us is a little different, of course. And that is also hitting us wherever we are and whatever our baseline experiences have been. So it's really kind of, in a way, a compounding effect, especially for frontline health workers who may have already been vulnerable or at risk for reasons that were, very much pre-pandemic. the barriers to care still need to be addressed during the pandemic, all the more so. And I am happy to say that there are a number of things going on to, in fact, ramp up those efforts. Just like I explained at the national level, that political will has just really opened up. Well, I think the same thing is true for healthcare workers. And there could be a much longer tail to this experience of distress, and our ability to measure, in the national CDC suicide data, we only have preliminary suicide data for 2020 so far. We have yet to even see the finalized data. That means we don't have an analysis of rates. We don't have it broken down by demographics or states yet. Now, some of the states have done their own deeper dive. And so we have from a few states, some more granular information. But when it comes to healthcare workers and physicians, we don't have data. And what I will say even about the issue of measuring suicide rates for any particular occupation, it is not a simple thing to do that. And so even when you see the literature and you wonder why it seems confusing or discrepant, it's because it's a difficult thing to capture. The CDC does the best they can so far, but the occupational sort of category at the time of death for death investigators is a little bit messy, and all healthcare workers are lumped together. And as I mentioned, there are a number of sort of industries that are known to have historically kind of the highest rates of suicide. Those are agricultural, construction, law enforcement, and I would say healthcare workers fall just under that, but still above kind of population averages. So there could be a longer tail to the COVID experience and the COVID impact on mental health and suicide, both for the general population, as well as for frontline health workers and the way that many lives have been affected by the pandemic and the exposure, the experience of PTSD and other things that obviously are a manner of suffering, but also place people at risk. And that traumatic impact sometimes manifests in a delayed way, so that we may be seeing more data, for years to come, I believe. Okay, so there's a lot of data points related to physicians and health workers during COVID. And this is one of the more recent studies that basically looks at both trainees as well as faculty and staff. And you can see that those who are moderately or seriously worried about the pandemic impacting their career development, as just one indicator, is pretty high, between about 50%, 46% of faculty and 64% of trainees. ACEP, the American College of Emergency Physicians, got very serious about suicide prevention after Dr. Lorna Breen's passing. And there are a number of things that are coming from that, and also in terms of advocacy efforts that are really wonderful, like the Dr. Lorna Breen Heroes Foundation and the Healthcare Provider Protection Act that has passed in Congress. That's the first of its kind. But yet, when ACEP surveyed its members, about 3/4 of emergency physicians feel there is stigma in the workplace towards mental health experiences and treatment. And there still is avoidance of mental health treatment. So again, this is not just a matter of like turning the switch on. These are things that have a long life to them and need to have very strategic and sustained efforts. Okay, I'm going to skip past this one. Okay, so let's end our time looking at what do we know from the evidence to say that there is a way to afford a population the best opportunity for reducing their suicide risk? And that's what we're going to talk about now in my remaining few moments here. Before we get to the question period. So there is, in fact, a public health approach, like there is to any complex health outcome and leading cause of death. A public health approach can be a very effective strategy that has to be multi-layered and can start with a very universal approach and then become more and more selective and targeted towards at-risk populations. But in the CDC's technical package, which is a community-based suicide prevention package of programs and strategies that CDC recommends, and I was part of this effort with CDC. These are the known from the evidence or best practice believed to have the best impact in terms of suicide risk reduction. And some of these can be applied to health workers and physicians because we are a community. We're not, so it can be a little bit confusing because we are accustomed to having our clinical lens on so much of the time. And if you're treating a physician or a trainee, that certainly is appropriate to have your suicide prevention clinical practice lens on. But what we're talking about here is more of a community-based approach because we are each other's colleagues and we are in an academic or a healthcare institution where it's more of a workplace or community approach. So now, I want to make the point that sometimes when we hear about burnout or suicide prevention among health workers, it can sort of imply something that I really don't mean to imply. So I want to just say it explicitly, that I see suicide prevention as a shared responsibility between individuals and organizations, and both have a really critical role to play. During just a few months ago, I did publish this paper with some wonderful colleagues on preventing clinician suicide, a call to action during the COVID-19 pandemic and beyond. And what I just wanted to point out here is that what I'm particularly happy about what we did in this paper was, it's a beautiful actually narrative that includes some experiences of Dr. Breen's family sharing their story, and Dr. Michael Myers looking at it from everything that he's learned from the family members of physician suicide decedents. But at the end of the paper, we listed out very practical things by a person's role. So you'll see there that if you are involved in a hospital privileging board or a licensing board, that there are very specific changes that need to happen and recommendations, actions to take. If you are part of a professional association or a continuing education entity, there are things there. For medical educators, there are a whole lot of very practical implications, including something as basic as modeling a growth mindset. So that says that we all struggle at different times, and it's actually a sign of strength to address those challenges, and we can talk about those. The person who can model that in a way that makes it safe for trainees to take their step towards opening up and getting help, that can be a very important thing that can also just sort of change the sense of safety and support in a work environment. And then for individuals, there are things that I'm going to talk about here in just a moment. I just want to make one point that is, I think, sometimes unspoken, which is that I think there's been a long-standing conflating of mental health and psychiatric conditions, particularly addiction, with an assumed threat to safe practice and competence. And I want to just pull this back and understand that that may have come out of a time when so much of more mild or moderate psychiatric conditions and substance use problems were underground. So by the time we saw them, they were self-selected to be so severe that they were more likely to be jeopardizing physician practice and safe practice. But the truth is, just like physical health conditions, the earlier you catch it and more proactively you address it, the more likely it is to have no impact on actually impairing work to the point of incompetence. We know that there can be impacts on work, right? But when we talk about impairment and unsafe practice, that's a very different standard than the more nuanced issues that have been studied related to burnout and depressive symptoms affecting cognition and empathy. So the way that I would frame this when I was advising students and trainees and colleagues over those years as a dean was I tried to put it into the model of both, using physical health as a comparison, that we would go get a professional medical evaluation, and we hope, sometimes physicians aren't the best patients in general anyway, but this, not all, that's changing actually, and especially with the younger generation. And also female physicians are, because we're females, we're socialized from an early age that we engage in medical care, but that's important for every physician and every healthcare worker. Now, I also tried to put it in the frame of, for an elite athlete, why would they not avail themselves of the best coaches and training, and sort of to get their psychological mindset synced up with a honed performance? Because we know that there is a mind-body connection, and executives would engage in executive coaching. So many times that was a way to sort of like help them understand that psychiatric treatment, and especially therapy, could serve that function for them, even if they didn't have a diagnosable mental health condition. Now, this reservoir model is something that I came up with and I published on long ago, again, came out of my work advising students, where I could almost sense where a person was in terms of running on empty, or whether they were finding ways to keep their reservoir more full. There are things that naturally drain our resilience reservoir every day. And some of us have leakier tanks, and some of us have more robust reservoirs than others, but there are things we can proactively do that will help fill that up. And so you can think about this from a psychological PPE sort of analogy during COVID, that we have to be extra vigilant. So that's sort of the individual level. But on the organizational level, there are a number of things that can be done and are happening at various institutions around the US. And I put them into these buckets for this slide. There are programs that really emphasize connection and interpersonal connecting through mentors, and time set aside for that. There are educational strategies that can be very, very important. What we know, though, about barrier reduction and suicide prevention overall, and that barrier reduction section really is covering the programs, and you see that COPE Columbia, as well as the program that I helped start at UCSD, are mentioned there as prime examples of multifaceted, multi-pronged, really mental health and barrier reducing, and even suicide prevention can be one of the impacts. Now, just to say a word about your own program, COPE Columbia, Dr. Laurel Mayer is a friend and colleague of mine, and I know that she and the team there have been doing this work for years, and then during COVID got more creative and proactive, and it has been met with an increase in engagement to the program. So I want to highlight that, because if you are someone who has yet to kind of know where to go, what is safe to do, or to even to explore what it is that you might be experiencing, I would just point to this program as something that many of your colleagues across clinical departments at Columbia are in fact engaging in. You can see that there's been a 25% increase in calls during COVID to the house staff mental health service in particular. Now, let's see, how am I doing on time? Oh, I need to wrap it up. So it is important to reach out if you sense that a colleague may be struggling, and I would just open up a private, safe space and let them know that you're not judging them, that you're there to support them, and it's okay to ask them if they're having suicidal thoughts. Don't be confused. You're not being their clinician in that moment. You're being their friend, their colleague, or as a faculty member, their mentor or advisor. At AFSP, we've had a longstanding interest because our founder, Herb Hinden, and then Paula Clayton and myself all had a special interest in physician suicide prevention. And we've developed postvention toolkits for after a suicide, for medical schools, for residency programs. Just last month, we worked with the AMA to launch a program that is a toolkit that's really for any physician suicide that occurs for any health system to be able to respond. So know that these resources are there, they exist, and they're freely downloadable. I will just end by saying there are actionable strategies that can be taken and that are being taken at your institution. And there's always more. It's always a learning journey for all of us who do this work. For anyone who is looking for external resources, these are some of my favorite ones, the national crisis lines, but then there are clinician support lines specific to physicians or clinicians, and then the AFSP resources. And so I'll end there and hope that we can have a nice dialogue and Q&A. Thanks.
Wow, Dr. Moutier, what an amazing talk. And so inspiring to hear how you took a very personal, distressing moment early in your career and used it as inspiration for change and to create meaning out of that experience. It's really, really inspiring. And I think you touched upon so many things that were occurring that I was curious about related to the topic about what is unique and distinct about physician risk for suicide and what aspects of our culture in medicine and personality traits that are consistent with what makes a good doctor that can actually be risk factors. So thank you so much for a great talk. We have some questions that have come in the Q&A, and I just want to invite other people to continue to post questions in the Q&A.
Jeff, before you start, can I just take a prerogative of asking one thing that's maybe a little more off point of what a lot of the other questions will be, and then I'll desist. But Christine, one of the things that we've encountered prior to COVID, but more so even during COVID, is that when an initiative is made by a psychiatry department or any sort of constituency within an organization to address the issue of employee health and well-being, and with the idea of alleviating sort of workplace distress and its most serious consequence, something like suicide, you run into territorial or systemic issues. In other words, within the hospital, the medicals, is this an HR issue? Is this an occupational or health issue? And then at the university level, since student suicide has also been an issue, the boundary between student health services versus what the medical school may have to offer in terms of expertise or effective ways of trying to address it. So do you have any words of advice or insight as to how you manage these kind of systemic structural issues within organizations?
Yeah, it's a really important point and question that you're right. Every institution has a sort of different flavor and version of that going on, especially, early on, because the same thing was true at UCSD. It had been the case that the Department of Psychiatry and a couple of faculty members in particular were like the ones seeing all the medical students, a lot of faculty, a lot of residents. And then when the LCME made the line in the sand that any faculty who has an evaluative function or role with trainees cannot treat them psychiatrically, that was sort of a major shift. And I will say, as an academic psychiatrist, when I was at UCSD, who then joined the dean's office, and so kind of spanned staff and the administrative function, and I became very deeply involved with the campus counseling center for the main campus as well, that I found that there was a way to kind of delineate roles, but have room for everyone. Everyone has their expertise, and the ideal is that it's coordinated and obviously friendly and kind of working together towards the best interests of the trainees and community members. And sometimes, and I think from the trainee standpoint, we know that whatever feels the safest, it needs to be like a no wrong door kind of situation. so that if there is a way for them to explore what is the way that I'm comfortable, and of course you want the service to be effective in the end as well. But, so you have to kind of think of it from both angles. I think the coordination administratively and across departments and areas of the university, but then always have an eye towards how do we make this streamlined so that it's lowering the barrier and not, kind of increasing barriers inadvertently.
Great. Thank you. Dr. Moutier, before we go to trainee questions, before the talk, you were mentioning the upcoming conference to me. I'm wondering if you want to make a plug for that and we can put a link in the chat.
Yes, thank you so much. Yes, so again, this department has a higher density of clinicians and researchers who have been leading the way really in the suicide research field. And at AFSP, we've been collaborating with the International Academy of Suicide Research, that's IASR, for a number of years to co-host an every 2-year International Suicide Research Summit. And that is coming up October 24th through 27th. I would really love to extend an invitation to all of you, if you have time, to participate in it, to register. It's purely virtual this time. It was supposed to be in Barcelona. So hopefully 2 years from now it will be. But yes, please, if you have any interest, and if you are somebody, early in your career and you're sort of undifferentiated as of yet in terms of your area of research focus, please consider coming. And there are ways to be mentored and brought into the area of suicide research. And you certainly are in one of the best departments in the world for that.
Great, thank you. And Simon just put a link in the chat to the conference website. So I'll now ask a question from Nina Gao, a trainee and psychiatry resident, who says, in the initial report in JAMA from CDC in March, suicide deaths fell in 2020. You mentioned that for a variety of reasons, these data may be incomplete. And she's wondering if you could say more about the abnormalities and to what you attribute any discrepancies.
Well, that was preliminary 2020 mortality data that the CDC was reporting on. And then there were a couple pieces in JAMA that were specifically focused on suicide. We're still waiting actually for the finalized CDC mortality data for 2020, specific to suicide. And so it's not that we have any reason to believe that it's going to be terribly different than that preliminary data, but all we have is the absolute number of suicide deaths preliminarily. And it showed that there was a 5.6% decrease in the number of suicide deaths from 2019 to 2020. What I am saying and hinting at is that sometimes doesn't tell the whole story, because we know that some demographic groups like communities of color, LGBTQ people, anyone who also had additional negative impacts of the pandemic for a variety of pre-existing health disparity reasons or otherwise, that there may be cause for concern. And so specifically, Black Americans, Latinx Americans, what we've seen from the 2 states that did a deeper dive analysis, those are Connecticut and Maryland. We see that Black residents in those states, suicide rates went up rather than like that overall trend of them going down. They went up, and in one case actually exceeded that of white residents. We don't yet have youth suicide data yet. We see the ED data coming out from the CDC's surveillance program, which is looking at, I think it's 48 states' emergency departments now, collecting up the data around suicidal presentations to emergency departments. But that can so easily get confused for suicide rates in the minds of like media reporters and things like that. So we have to be very careful about that, because if they're coming to the ED for having disclosed that they're having suicidal thoughts, and let's say their parents pick up on that, what it showed was that girls 12 to 17 years old, ED presentations went up, and that is concerning, went up by 50%, whereas the boys did not go up by 4%. And older young adults, 18 to 24, did not go up, year over year either. But sometimes what we see very strongly is that signals of what looks like you just have a much sicker population because the help-seeking behavior went up. Sometimes that actually correlates with decreased suicide rates. Now, the ED data is a little less clear because some of them may have already attempted, but nevertheless, if they are being linked to services, there could be a positive in there. So that the data, we're basically waiting to learn more. And specific also to physicians and health workers, I think it's going to be some time before we actually have like suicide rate data, which is hard to get, over time in normal years.
Great, thank you. The second trainee question was really about resources at Columbia, but I'll read it because I think it's important. Pablo, who's a psychology intern at CHONI 6, talked about co-leading an ACT skills-based support group in a previous location at UCSF for residents on the HEMONC service, and was asking what sort of support is provided to residents and medical students here at Columbia. So I know you touched upon that, and I just, so you know, Dr. Moutier, I did put a link to the COPE Columbia Clinic in the chat as well. And so Pablo, I would direct you there as well. I don't know if you have other thoughts, Dr. Moutier, about that.
Unfortunately, I don't have the granular information about about the services there. There could be, I know Dr. Mayer needed to leave early, but there could be other members of the team that may want to chime into the chat if you have any replies.
Yeah, so unfortunately they weren't able to stay, but I think probably the COPE, I just wanted Pablo, to recognize your question, and I think the COPE Columbia link is a good place to start that's posted in the chat. And then the next question came from Dr. Ralph Wharton. He's asking whether there are enough special programs for women physicians who delay pregnancy or who become mothers during training. And I guess to link that to the topic of the talk today, if you have thoughts about how those impact issues related to suicide risk, will these programs help reduce stress on women?
Yeah, women's specific efforts and programs are, I think, fewer and far between. There are some, and I've seen, for example, a women physicians empowerment groups on social media. I've seen them convening for coaching, which is a really interesting phenomenon that's happening amongst mostly female physicians, which to my eye, I don't know all that they're doing. It's peer-to-peer, and it's things like career advising support. But what I observed, my little dip in spending time with them, is that they're promoting growth mindset and some sort of changing the narrative of our, which basically sounds like a sort of lay version of CBT, of sort of, rewriting the automatic negative thoughts. So, what I would say is, for us women in medicine, I think the most important thing is that you find what works for you, that you're not feeling, kind of zipped up and sort of silenced by shame, stigma, or anything else. That of course we bring our professional selves to the workplace, and however, in a healthy work environment, there are safe people and safe ways and places where we can talk about lots of stuff that we're going through. And it's there are obviously healthy boundaries and everything in place, but some of the most powerful programs that I've seen, not specific to women, but I would just encourage thinking about this, are facilitated process groups. So those can be peer-to-peer. I don't know if you have those as part of the residency program at Columbia. I see you.
We do, yes.
That's awesome. I had that as part of my residency experience. And while you're going through it, you're kind of like kvetching about everything. It doesn't necessarily feel that impactful. But I look back on that and I think we learned how to talk to each other and share at a pretty deep level, and just communicate in a way that, again, if the overarching environment can promote that kind of authenticity and dialogue, that can be extremely helpful. And again, I think if kind of veering away from that question about women a bit, just for a moment, if I may, if you're in a position of leadership in any way, a training director, a faculty member who's leading a team, and you're seeing behaviors that could be indicators of deteriorating mental health in a worker or trainee, what I would say is keep your health frame squarely on your head, because we get very confused and squirrely when we see that and we start thinking about performance and, automatically sort of linking the two. If there's no reason to be concerned about performance, big P performance, then think about the health issue and think how you would go to that person if they we're talking about maybe having an early diagnosis of diabetes or anything else. You would express concern, you would express support, you would say, can I help anyway? Do you need information? Do you need formal or informal accommodations in the workplace because of something health related? They would have the opportunity to disclose or not disclose about what their diagnosis is, so that health frame can be a very grounding anchor for addressing those kinds of concerns in the workplace.
I was going to ask a related question because there are many people on the Zoom and from so many different places in our department, but what we all have in common is we all have colleagues, and many of us have supervisors, supervisees, and about asking to expand more on that sort of granular, on the surface level, like down on the ground level, about how what are the best ways to support colleagues, peers, et cetera, in the work setting and the challenges of that. And I guess another challenge of that in 2021 is that, we're all still doing this hybrid, some remote, some in person, and how to connect with one another to express concern in a way that can be helpful.
Yeah, I know. I actually, probably because of my experience over 10 years as a dean, probably thousands of meetings with, just really hearing what's going on with trainees and faculty alike. And I learned very quickly that every one of us is a full human being with a full set of family, health, mental health, work-related sort of issues going on, every one of us. And so while it might sound a little bit, reductionistic or something, what I learned to do was to go by a sense of, when you know your colleagues pretty well, you work with them day in and day out, their behavior patterns are, you observe them. You can't help but, make that observation. You're not being their doctor. You're just being, an educated human working with them. And when your gut tells you something is veering off course, and, again, that may be where a little bit of clinical instinct may come to bear. But even I think lay people can do this when it's not just a bad day, but when it looks like something is that, and I'm talking about it may have seemingly nothing to do with mental health. It could be that they're usually a person who gets everywhere they get 5 minutes early, and now something else is happening in their usual patterns. Maybe connected to a couple other things, like, I don't want to make a mountain out of molehills, but I also think that what does it hurt to address a person in a caring, supportive manner, where you give them the opportunity in a very safe, supportive space to share if they want to about what's going on. And the way I approach people is I say, I'm coming to you because I noticed that X, Y, and Z, and there's no judgment here. You're not in trouble. You have to say that right up front, because people will be like, oh my gosh, I'm in trouble. But I'm approaching you because I care about you. And I want to give you the opportunity to share about things that are going on from your perspective, so that I can support you as a colleague. And really just very open-ended like that. And then again, when people start talking, it's going to be about the circumstances of their life, right? They're not going to come out and say, here are the symptoms that I'm experiencing. Even though we're clinicians and work in a clinical environment, we're going to talk about, it's been really stressful at home because, the losses that I've occurred, my family's going through this, my kid, my spouse, my work life. So it's the way that they talk about it. If there is an overtone of feeling trapped, like they feel like they're a burden to everyone around them, a feeling of hopelessness, those are obviously all indications that they have been zipping it up, just like that little, I don't know, I flashed by it, but that had the screen of the shoe that looks perfect on the outside. Everyone looks, shiny and polished, but on the inside, there's often a different story that's going on. And those tonal indicators are oftentimes, in addition to life stressors being the point at which we use the language to express that to each other. But when somebody seems those ways, I'll say to them, when you talk about, and I use their words, when you talk about whatever it is, your dog dying, your work stress, it seems like it's very stressful to you. And it makes me wonder if you've had any thoughts about ending your life. And I put it out there. That's not the first thing that I would say in a caring, supportive conversation by any means, but if it seems relevant. But I think the issue is that we've been withholding that question for a long, long time because we haven't known if it's appropriate. Is it illegal in the workplace? Like, do I have to report the person? We've been so confused about suicidality as a human experience that many, many people, including medical people, experience at different times. And it doesn't necessarily mean they're about to act on suicidal thoughts. So you don't drop everything and walk them, you just stay in the conversation. You support them. You hopefully help them move to a point where they are willing to talk to somebody else about it. Ideally, that could be the official, COPE Columbia. It could be if they trust their training director but you're their colleague in that moment. That is not a reportable, that is a health phenomenon that you've encountered, and you want to do everything you can, but they may have had on and off suicidal thoughts over time, over years even. So I would follow up with them if they're not in a place where they're willing to get help in that moment. But unless you have reason to believe that it is an imminent cause for concern, it's handled like other high priority, very important health concerns that have been disclosed.
Wow, that was so powerful. I'm so glad that to have you model that conversation. I think that will be tremendously helpful to everyone on the call. And I think that's a really powerful way for us to finish our session. So Dr. Moutier, thank you so much for your time and for the amazing talk and for all the work that you're continuing to do.
I so appreciate the opportunity. Thank you, Dr. Miller, and thank you, Dr. Lieberman.